Good morning, everybody. Okay, so for the next few minutes, I'm going to be speaking about a rather less sophisticated application of diffusion imaging, and that's for the whole body. Now, as we stand here in 2017, we're actually in a pretty difficult place, particularly when we think about the imaging tools that we have in the clinic. So, oftentimes when we say the patients have no metastatic disease, M0, patients do have metastatic disease and we don't know it. And when we think patients have oligometastatic disease, 1, 2, 3 metastases, in fact they have multiple metastases. And I'll show you an example in a second. The second thing is, as we talk about our patients, the current imaging modalities, particularly in the bones, don't allow us to spot non-benefit at an earlier enough time point for us to be able to change treatments in time. And I just thought I'd give you an example. So here is the whole body MRI scan. This is a whole body diffusion sequence. This is a B900. Just for an illustration, here is the standard of care bone scan in somebody who's got prostate cancer with a raised PSA. Now, you can see retroperitoneal lymph nodes. The bone scan is normal. After 13 weeks of treatment, enzalutamide, which of course is now licensed, you can see that there's a reduction in the signal intensity of the lymph nodes. The bone scan is normal, the PSA is suppressed. So the current tools seem to work fine. Yes, you can see how everything works quite well. Now at week 25, you can see the PSA is still suppressed, so your current tool says the patient is responding. The bone scan is negative, so everything seems to be okay, but here we have a lesion. How do we know this is a lesion? Well, because of the whole body MRI protocol, and we have 2 prior scans, we can go back and say, what is that lesion? Was it there the last time? And it wasn't. This is a new lesion. So this, in fact, constitutes what we now call oligoprogressive disease. The problem is the standard of care is not whole body diffusion imaging or any other technique, it's the bone scan. So the bone scan is negative, as you can see. So what happens? The patient receives more treatment. Now we are at week 37. The PSA is still suppressed. Okay, the bone scan is negative. The bone scan is now positive. So shows 2 lesions. The whole body MRI scan is now showing 1, 2, 3, 4, 5 lesions. Is this progression? The answer to that is no, because a bone scan abnormality has to be confirmed before you say something is progressing. So another 12 weeks goes by, and now we have more lesions on the bone scan, so this is now progression. And we see all these lesions on the whole body MRI scan. Now the problem is, we saw progression at week 25, right? We confirmed progression at week 50, 25 weeks later. 25 weeks of a treatment that wasn't working. Why? Because we are using standard of care. What is standard of care? PSA and bone scans, which is why I call it bullshit scans. Because what's happened in this particular instance is this patient was given a disservice. You went from a cc of tumor to what looks like 50 cc's of tumor, right? And what were we doing? We were like this, right? We were like horses like this. So, and you know what they write in the clinical notes? They'll write the middle thing, so they don't look so bad. This is what is happening in the clinic today. Now, many of you will say, but you know, there's not only bone scans, but you've also got CT scans. CT scans work well, and they seem to work well in the clinic for soft tissue disease, and all of you are cognizant of that. But for bone disease, you really need to be very careful. And I'll just show you an example of somebody I saw not very long ago. So here is a lady with metastatic breast cancer. We can see a normal CT scan. We see a diffusion shows a multiple bone lesions. The patient goes on to an aromatase inhibitor. Okay, so the patient goes on to aromatase inhibitors. We know that there is primary resistance that occurs in about 30% of cases. And so she goes away from my department, goes to another hospital where they use standard of care. Standard of care is what? CA15-3 and CT scans, right? All of you are doing this. So she has another normal scan. This is called stable, okay? She receives more treatment, but she comes back with bone pain. Okay, she comes back with bone pain. The CT scan at this stage is abnormal, but you have to look pretty hard. There's a lesion here, and there's a lesion here, which is a little bit more conspicuous. The CT is suspicious for progression. All you have to do is to look at the diffusion scans to realize what you have in front of you is a disaster, right? Because what has happened, of course the morphological scans confirm this, because so what has happened is you've gone from 53 cc's of tumor at the start to 500 cc's of tumor, right? And why did this happen? This happened because you used a CT scan in the middle. That's it. And we know 30% of these patients don't respond. 33%. So do we have any idea what happened at time point 2? Do we know whether this patient progressed this whole direction? Was she stable and then did she progress? Or did she get better then progress? Do we have any idea? The answer is nada. We know nothing. And what is the problem? The problem is a log more tumor. A log more tumor. And now she gets treated with a chemotherapy at this stage, whereas you could have played around with less toxic treatments weeks beforehand to try to stop her getting chemotherapy. And this is happening in front of our eyes as we speak. The other problem with CT scans, particularly with regard to bone disease, is that sclerotic progression and sclerotic response are really difficult to evaluate. And that's because mineral changes that you see on a CT scans is due to the interaction between the tumor cells and the matrix cells. In other words, the stuff you see isn't necessarily related to cancer. So here is something that all of us recognize. Right? This is sclerotic progression. You can see this particular patient is developing new focal areas of abnormality. All of us would call this progression, and all of us would be correct. Okay? Now, take this very same patient. So this was with a PARP inhibitor. The same patient, and now we treat her with carboplatin. When you treat it with carboplatin, you see new lesions. So, for example, look at this lesion here. Look at it over here. Look at this lesion over here. And multiple new lesions appear. Now, is this progression or is this response? Now, a lot of us would say this is a response. I know some of you would say this is progression, right? This is the problem. It can be really quite tough. So if you see a well-defined, homogeneous lesion that appears, that has a Hounsfield unit of greater than 850, we can be pretty confident that that is response. But what do you do about a lesion like this? Here, you can see an irregularity along the margin here. Is that active disease? Is that inactive disease? Who knows, right? Nobody knows. Okay? So how can we get around this? So there are issues with CT scans and bone scans, and whole body MRI scans are a way of getting around some of these issues. Now, we know that diffusion imaging as part of a whole body MRI scan detects more lesions per patient and fewer benign lesions. And there can be no doubt about it. So here, for example, is a FDG PET scan in the middle, B900 image on the left, and the planar bone scan on the right. Now, this patient has lung cancer. Now, so why are we doing this examination on the right? Can somebody tell me? Because it's cheap. Patients trust us with their lives, and what do? Something that is cheap. Think about that. Okay. Now, we should be doing next generation imaging, like whole body imaging or PET scanning. That's what we should be doing. That's next generation imaging. Okay? And even the CT scan, same patient, right? That shows one metastasis, completely underestimates the volume of disease. Just to nail that into your brain. Now, numerous meta-analyses have now appeared, okay, with hundreds of studies, 145 studies in this particular meta-analysis. There cannot be any doubt, that the performance of bone scans suck, okay? Yet we still continue to use it, and it's still in every single guideline, okay? We need to change the minds of our clinicians. Okay, now clearly there are false positives and false negatives that do occur, Okay? Like any other technique, there are false positives and false negatives which you need to be able to learn. Okay? If you decide you want to do this in the clinic, be careful, because your clinicians will come to you and will pay you good money for this because they recognize it's important for them. Okay? You can see this is our activity over the last 6 or 7 years. So you can see in total we are doing between 80 and 100 scans per month in my center. Okay? That's what we do. Now, if you have a bigger center, you'll do more. If you have a smaller center, you'll do less. Okay? But who's referring patients? It's these guys here. Look, who are these guys? Breast cancer, metastatic breast cancer. So all of us have metastatic breast cancer patients. Who else? Ah, the prostate cancer people. Look at that. Right, so the prostate cancer people, there's also new business if you want to go down this route. So what is driving this in the clinic? What is driving this? It's because we know that bone scans perform poorly for detection and for response assessment. We know that CT scans are not that great for bone disease, and prostate cancer, breast cancer, that's where the bone disease occurs. We also know that normal tumor markers also don't behave well. Now, we know, for example, that PSA works quite well initially, but when you become castrate resistant, then PSA works less well. We know that CA15-3 does not work well. We know, for example, that you have oligosecretory disease in multiple myeloma. So these are all indications that you might want to explore. And in fact, whole body MRI scan is now making its way into the guidelines. So many of you will have seen this International Multiple Myeloma Working Group recommendations for the use of whole body MRI scanning for multiple myeloma. It's there. It's in the recommendation. You should be doing it. Right? So look here. MRI is the gold standard method for detection of bone marrow involvement in multiple myeloma. Recommendation A. This is not going to change. The evidence is so hard, this is not going to change. Right? Look what it says here. MRI is the procedure of choice for evaluating painful lesions of the spinal cord and cord compression. I think all of us can agree with that. MRI provides visualization of soft tissue extension and extramedullary plasmacytoma, grade A. Okay? So these are all grade A recommendations. You should be thinking about doing this in your own clinic. So this is an example of a plasmacytoma. Okay? This is our own UK NICE guidelines saying exactly the same thing. So that is a solitary plasmacytoma. Okay, you can use that image to do radiotherapy or surgery or biopsy in this particular instance. Then, in multiple myeloma, when the markers start to go back up again, you can then re-image and you can show that this particular patient has converted into multiple myeloma. So you can see multiple lesions in the bone marrow that were not there previously. Okay? This is how you can use this technique. We use it for prostate cancer and breast cancer. One of the areas that we use it and find it quite useful is to look for oligometastatic disease, So here, for example, is a patient who has got a rising serum PSA. Here is the lesion there. We use the diffusion imaging to do some radiotherapy planning, and you can see what happens with treatment. The lesion goes away. This patient has had 3 further CyberKnife radiotherapy planning sessions on diffusion imaging. Okay? Now, this was 2013. His PSA today is still 0.05. Okay? So we've gone 4 years. We've spot welded 3 or 4 lesions. We haven't started any systemic therapy. The problem with starting systemic therapy is that you induce mutagenesis in tumor cells, and these tumor cells, and you are almost always dead in 5 to 7 years. So remember, there's a danger of starting hormonal therapy too early, because once you start hormonal therapy, you are dead in 5 to 7 years. Keep the gun in your pocket for as long as possible. When you need to start hormonal therapy, start it. But for oligometastatic disease, you may want to think about doing ablative therapies. Now, we also use this technology to look at response assessment. So here's a patient with metastatic disease who is getting better on diffusion imaging. So this patient has prostate cancer, and you can see this is before and after 4 cycles of docetaxel treatment. Now, many of you will say, why do I need to do diffusion? I can just look at morphology. Here's a nice example of how morphology does not help you. Does not help you, right? So look here, for example. Here is the T1 sequence. It looks worse. It looks worse. You are in danger of saying this patient is worse, right? Actually, is better. And you know what? A policeman can say this is better. You don't need a radiologist to say this is better. Now, one of the things you can then do is you can start to color code the ADC maps, giving you like a traffic light system for your clinicians. And I do this now for my clinicians all the time. I give them a traffic light system. Bad, okay, good. Okay? So red is bad, yes, yellow is dying, and green is dead. So here, for example, is a red, and here is, you can see that after 4 cycles of docetaxel, you can see large amounts of dead areas and areas that are still viable in a number of locations. And you can use the ADC to tell you that, right? Because the cutoff of 1500 in this particular instance is pretty good for saying this is cell kill. Okay. Now, the way you kill cells depends on the biology of the tumor. Okay, so if you kill cells with chemotherapy, it's like homicide, right? You kill loads of cells. You big gun, shoot into a crowd, loads of people die, right? That's chemotherapy. Okay, and that causes a very different picture to apoptosis. So here's a patient with breast cancer. Again, you see here on the T1, you might say this patient is worse. Actually, it isn't. This patient is better. How do you know? Look at the diffusion sequences. Look there. But to your clinician, just show them a traffic light. It was red before, it's green now, right? That's all you need to tell your clinicians. Keep going, you are doing fine. This is a very typical effect of a chemotherapy. You can see the histogram shifted to the left with the majority of pixels above that 1500 cell kill range. Now, if you were to use hormonal therapy, it looks very different. Hormonal therapy looks very different. So hormonal therapy kills 1 cell at a time. There's no bystander cell kill. There's very little edema in the tissues. So here, for example, if you looked at that, you would say stable. Okay? T1, T2, diffusion, the projection image, you say stable. But you do the quantification, you can say response for sure. Okay? Because you can see that shift of the histogram. Not only do you see the shift of the histogram, but if you back project it, you can see that there are areas of cell kill and of viable tumor all intermixed, right? This is typical apoptosis. When you look down a microscope, that's what you see. You see a cell die here, another one die over there, and then the rest of the cells are viable. This is exactly what happens. And that's what you see also on your pictures. So in terms of where are we going? Well, standardization is key. Standardization is key. And in fact, you know what? The standards have now been published. So all of you can't say there are no standards. There are standards. Okay? Here is the paper where the standards were published. And essentially, there is a core protocol and there's a comprehensive protocol. Please go and look at this publication. It tells you what to do. The detection core protocol takes 30 minutes for the whole body. 30 minutes for the whole body. If you want to do response assessment, it takes a bit longer, 45 minutes. Okay? This is not an impossible examination that takes 3 hours. Okay? So for some of those, I know that I get complaints that the patient was in the scanner for 3 hours, and I'm going, what the hell are they doing? Right? 45 minutes. Okay? Not only is there a protocol, a quality standard, but we've also established a method of a reporting system. So there is a reporting system. You can use the reporting system, and there is also the criteria for what is response and what is not response. Okay? The criteria are now laid out in this report. So these criteria are based on your pictures. So the pictures on the left is what you recognize clinically, correct? So what we've done is we've converted those pictures on the left to words on the right, and that is a scoring system. So you can then say, you can take a patient like this who is progressing to hormonal therapy, and you can say, this is progressing, but you can report back to your clinicians and say, give them this report that you normally would do, snapshots of the pictures, but also this MET-RADS report, which basically says which sites are involved. Are they responding? Are they not responding? Okay? This is all well documented in the MET-RADS. Now, for those of you who are taking, this lecture is on YouTube, so you can go and watch it afterwards. It's not a problem. Similarly, for response, okay? Again, we have incorporated diffusion imaging and morphological sequences to report back to your clinicians. And again, we have converted those pictures into words, and then those words you can use as a scoring system. So here is that same patient that the policeman could see that this patient is better, and then you can report that back to your clinicians also. Now, so you can see that that's the MET-RADS system. Now, many of you will say, do I need histograms? The answer is no. Histograms are sexy. Histograms are great for lectures. Do you need them in real life? No. Okay? But it helps you explain. But what you have to remember is that that is the direction of travel. You heard radiogenomics being mentioned today. These are the direction of travel. So as you move in this direction into what we are now calling next generation imaging, you will have to get used to histograms and displays like the one I've shown you, but this is a direction of travel that you guys will need to think about as you go forward, okay? Now, if you think this isn't the way forward, look at this paper that was published in Radiology recently, looking at changes in ADC after using a novel new method of treatment of prostate cancer. So remember, personalized medicine is coming your way. Like it or not, personalized medicine is coming your way, right? Personalized medicine, what is personalized medicine? Personalized medicine is where you do next generation imaging, whole body MRI, PET scanning, etc., all these sexy tools, plus genomics. You do radionomics, you do biochemistry, you do circulating tumor cells, you sequence it, then you decide what treatments to give a patient, and then you use that to titrate the patient's treatment over time. This is personalized medicine. Personalized medicine is coming in your direction. Get used to it, right? Get used to it. It's coming in your direction. So you need to be able to get your brain around this, because this is what your clinicians will want from you in the future. If you want to see an example of personalized medicine and how you can use diffusion imaging in real life, in your own practice, let's see what it looks like in real life, then I've got this YouTube example. You're welcome to go and take a look at it. And this lecture also today is also there. Okay, so here are my concluding slides. There is no doubt that whole body MRI scanning with diffusion imaging will be part of personalized oncology. It will be part of personalized oncology. You just have to make the transition yourself in your own brain. It is there in the guidelines already for multiple myeloma. Imaging standards have now been published. Okay? You cannot say they are not there. Okay? There is a real potential for you to start to change the way that you think and the way your clinicians think, particularly about metastatic bone disease. Because not only can you say progression, non-progression, you can take the next step. You can say this patient is responding, this patient is stable, and this is progressing. So for bone disease, you convert your normal paradigm of stable, progression into three categories: response, stable, and progression. That promotes personalized oncology. That promotes personalized oncology, which you know is the right treatment for the right patient at the right time. The question is, will patients live longer? And we think the patients probably will. Is this going to be related to whole body MRI scanning? No. A scan never makes a patient live longer. It's treatments. But it's because we help titrate treatments that people will live longer. Thank you very much.